Right, I think we're going to get started. I know some people are still logging on, but we'll get started with a brief introduction. My name is Stephanie Kosner-Berzin. I am the Dean of the College of Social Sciences Policy and Practice at Simmons University, which contains the School of Social Work. I am a co-lead for the Grand Challenge, Harness Technology for Social Good, which is sponsoring today's webinar. Today's webinar is in Telemental Health, what digitally curious social workers need to know. We'll have 4 presenters who will introduce themselves in a moment. To kick us off, I wanted to provide a small bit of background around our Grand Challenge and why, in fact, we brought folks today together for this webinar. The Grand Challenges effort was launched about 5 years ago to bring social work together as a field in order to be able to look at what are the primary challenges for our field over a 10-year period for which we could make meaningful progress. There are 12 challenges that cover topics that include some particular social problems, and then our challenge, which is really one that's more related to the field more globally. Our challenge was designed as harnessing technology for social good. And the goal was really to begin to get social workers on a path to think about transformative change that occurred because of technology and how it would fundamentally alter our practice. The challenge is made up of 2 distinct groups, one that focused primarily on practice and how social work practice would fundamentally change as a result of technology, and the other group that was focused on big data. Why we came together was that we recognized as social workers, while the world was moving incredibly quickly in terms of information communication technology, but was fundamentally changing access, changing communication, changing where people receive information, the field of social work had been slow to move forward in this progression. We feel there was an opportunity to really put time and energy toward bringing the practice forward through education, through research, through training. I'm just going to highlight for you a few of our main goals for what we hope to accomplish over the decade for which the Grand Challenges were designed. We're really interested from a policy perspective on opening up access, both around internet connectivity and practice across state lines, telehealth being one of those topics, which we'll address today. We're interested from a policy standpoint around data linkages and sharing. We're interested in data issues around how, in fact, we could train and attract social workers who could work with big data for social good, and how, in fact, we could use new technology-based interventions for practice. We wanted to make sure social workers were, in fact, controlling our destiny for how mobile apps and gaming and data would be used in practice. We also recognize that this is not the place for which we're the master of the domain, and instead that we hoped our Grand Challenge would begin to open up conversations between our profession and other sectors that are deeper in this work. There's already been a lot of work which the Grand Challenges have been part of in thinking about curriculum and pedagogy in this area, and we've been thinking more about how, in fact, we expand data access. This webinar is part of a series that we're beginning to host, and it's really part of that primary goal of how do we, in fact, develop, train, and retain a stronger group of social workers who are interested and more conversant with data and technology. So I'll just, as a sneak preview, share with folks on today's call some upcoming webinars that we have. We have 3 webinars in the series that are currently scheduled, one in June, one in July, and then one next September. If folks have other questions around the Grand Challenges more broadly, the Grand Challenges for socialwork.org website contains both our papers that describe the 2 parts of the technology challenge and the other 11 challenges. I'll pass it over to Lori Goldkind now, who will introduce the panelists and get us started on today's topic. Thank you so much and welcome to everybody.
Thanks, Stephanie. Thanks so much for kicking us off. I'm Lori Goldkind. I'm going to let my colleagues introduce themselves in a moment. I am an associate professor of social work at Fordham University in New York. I have been studying technology in various forms for about the last 8 years, and I'm very pleased to be able to share our stage with some folks who are in practice doing some of this work and share with you some of our research. And I'm going to let my colleagues introduce themselves.
I'm Leah Wolf. I'm a graduate student, a PhD student at the Graduate Center at CUNY in New York. I do a lot of work and research with Lori. We look at technology augmented social work and the potential of technology to amplify human capacity, and also the threat of online virtual worlds, how human rights are preserved in virtual and digital spaces.
I'm Nicholas Davis. I'm a licensed clinical social worker, and I've been practicing telemental health since 2017.
And I'm Caroline Artley, and I'm a clinical social worker with an online private practice.
Thanks, you guys. We are really excited to get us kicked off. I want to acknowledge for a moment, and I will invite us to spend a moment of reflection in a second. Today happened to coincide, our webinar coincided with an academic strike that I believe has expanded outside of academia. There's two hashtags associated with this shutdown for the day, shutdown academia and strike for Black Lives. And I want to start us just as a moment of reflection, because, and we'll talk about why telehealth has become more prominent in a moment, but I'm going to ask us to just take a pause and enter a moment of silence in honor of the shutdown. So thank you for joining me in honoring the strike and the shutdown. And now we're going to sort of kick off our overview for today's presentation. We really have two goals. We want to give you an overview of sort of the field of telemental health, which has some subfields embedded in it that we'll talk about. And then secondly, present this constellation of tools as an opportunity for realizing equity and access in mental health care. And that's, I think, a place that Leigh and I are both very interested in expanding both what we think of as mental health services and who has access to those services overall. And as social workers, our code is sort of present in how we think about the research. And I guess sort of one of the impetuses for presenting our findings now and for bringing Nicholas and Caroline in is, prior, I think, to the pandemic, there was a perception in the academic discourse about telemental health in social work, about whether or not we should be doing it. And when in fact, some of our data that we've collected is maybe 2 years old now. We know that social workers are engaging in telemental health practices. Some of them are running their entire private practice on their own proprietary platform and have built out a private practice using digital tools. Some of them are participating in third-party platforms. And so I think that we're really eager to put to rest the question about whether or not social work should be doing this, because we are doing this. And so, so that's sort of part of our perspective, the lens that we're bringing to this work. And so we have a question for you. And so we also, the visuals in WebEx are quite unique in that I don't see if our poll is being launched, but we're asking you, our audience, have you delivered telemental health? Has anyone engaged in this practice?
This is our first poll question, and for many people, we realize that your answer to this poll question might have been very different in January of 2020. A lot has changed, and the pandemic has drastically altered the circumstances surrounding this modality. There have been changes in regulation around licensure and around reimbursement, and so the picture is changing quite quickly. You have, let's see, 15 more seconds to answer this poll question, and then we'll get a sense of kind of where the group stands in terms of their experience. Okay. Let's see. So can you guys also see, let's see, I'm a little, okay. My technology is a little slow. Let's see. Are people able to see the results of this poll? So it looks like 22% of those participating have tried delivering mental health, 42% have not, and 36% didn't answer. So twice as many people of respondents have not tried delivering telemental health as have.
Thanks, Leah. So I want us to sort of approach our conversation about telehealth, understanding that practitioners have been engaging in trying to figure out how to successfully deliver mental health services since not exactly since 1924, but in the first iteration of this was happening in the 1950s. And I think that in lots of cases, we think about telemental health and delivering services in spaces that are not face-to-face as a new phenomenon. And in fact, the first supervision session and transmission was in the 50s and was delivered by a psychiatrist who was sort of attempting to prove that you could deliver supervision and therapy via non-face-to-face modalities. Not surprisingly, the VA, the Veterans Administration, has been pioneering telehealth, telemental health services for veterans in need for over 30 years. And the VA, we know, is the largest consumer of social work services in the country, as well as one of the largest employers of social work services in the country. And so exploring how to reach veterans in need and how to reach a potentially resistant population has been really on their research agenda for quite a while. We're going to hear more from our practitioner colleagues in a moment about how one enters into the practice of telemental health. We really, in thinking about how to package our information for practitioners today, wanted to make sure that you are leaving with some practical insights into how to start making use of telehealth tools and digital strategies. And just, I might have mentioned this earlier, the platforms of telehealth are quite wide-ranging. And so there's peer support models where there's no licensed professional engaged in service delivery and people are coming together to support each other. And that model is maybe characterized by 7 Cups, which also offers some professional services. Then there's professionalized models where third-party providers are brokering, if you will, the services of social workers, licensed marriage and family therapists, counselors, and they're sort of serving as a matchmaking platform to connect a client to a practitioner and managing all sort of the attendant administrative pieces. So the assessment pieces, the fees and documentation pieces are managed by the platform, and the professional is kind of providing the mental health kind of product. And then there's models that marry a coach with a licensed professional practitioner, and there's practitioners like Caroline who have kind of built out their own set of digital tools that is their own platform for delivering services.
So people are curious about the various ways that people become, that practitioners join the practice of. Let's see. Can you hear me? Great. In the research that Lori and I did, we interviewed a sample of practitioners nationally, and people had various different on-ramps to telemental health. For some practitioners, they had first tried it as part of agency practice, and then they began to explore it on their own. What was common to all of the practitioners we spoke to is that their entry into a broad telemental health practice came on their own initiative. So no matter how people sort of first heard about the practice, the pursuit of it was something that they took on individually. Some people tried it for what we might call life reasons. So pursuing greater flexibility around needing childcare or considering retirement. Some people wanted to augment their income because maybe agency work wasn't highly remunerative. For some people, they lived in a place where they felt either isolated from clients or they felt that clients were isolated from access to evidence-based practice. So there are a bunch of different ways that, or reasons or rationales that people started up with telemental health. The experts in this, of course, will be practitioners. So I wanted to ask first Nick and then Caroline, how did you hear about telemental health and how did you make your way into a practice? Nick?
Sure. So like you said, Leah, I kind of discovered telemental health on my own. I think I saw an advertisement for Talkspace at the time, not advertising for therapists, but advertising for clients. And at the time, I was practicing in community-based mental health. So like many of my social worker colleagues know, when you're in community-based mental health, you're usually visiting clients in their homes or in schools. So the territory that you're covering is quite large. And I was just looking for another way to kind of get some time back into my life to kind of cut down on some of the commuting time. And so telemental health, from a personal aspect, seemed to fit that well. So I reached out to a few platforms and found a home in one.
And like Nick, I was working in community mental health as well. And I was one of those life issues bringing me into telehealth. I was having a really hard time with childcare and had to figure out how to work from home. The clinic I was at was doing telepsychiatry, and I thought, well, if the doctors can prescribe medication virtually, why can't I deliver therapy virtually? So started looking into it and finding not a whole lot of information, found the platform BetterHelp at the time and joined onto that. And then from there, some of the other clinicians in that platform formed a peer support group, and we would kind of meet together online, and we would research what it took to do this on our own outside of BetterHelp. We would all take an assignment and we'd report back to each other, split up the work, and together we kind of started building our practices online outside of the platform.
Yeah, and it's interesting because each of you is in sort of a different space in telemental health right now. It's interesting to hear how you got there. Here is our second poll. We are curious about what people think about the potential of telemental health. And as Lori said, you once again, first of all, you have 1 minute to try and answer this question. But as Lori said, often when we think of these virtual modalities, we think of the future and moving forward, but we're also interested in this modality as a way to go backwards to the values that animate social work. So how the most number of people can gain the most appropriate and meaningful services. So we're wondering who you might imagine could benefit. All right. More people have to vote this time. All right, we're 37 out of 53. We got a, oh, 39. And I'll be able to show you what people imagined in 5 seconds, according to my screen. Yeah, so for 55% of the people who responded to this poll, you imagine that all of the above, all of these different populations might benefit from telemental health. And I think that, I mean, Nicholas and Caroline are the best people to speak to this, but these are all populations who have been shown to benefit from this kind of remote modality.
So in terms of effectiveness and who telehealth has been shown to be effective on behalf of, there's a lot of literature at this point that suggests that digitally delivered mental health services are as effective and comparable in outcome to in-person services. And so I think one of the things that that anecdotally that we've heard from students who are current MSW students is sort of a skepticism about whether or not you can kind of affect the same relationship or engage clients in the same way from a telehealth environment as they might in a face-to-face environment. And the literature, and this is just one review from 2013, which is about 7 years ago, the literature suggests that telehealth and digitally delivered service really is a comparable, if not more effective for some populations than face-to-face environments. And similarly, there's been a really significant interest in using telehealth in rural populations, and we've sort of seen that echoed or heard that echoed in the COVID since the pandemic. And so this idea about telehealth being sort of a far second to face-to-face therapy is really not, it's really disputed by evidence in the research literature. And so there's another sort of COVID kind of circumstance arising where a lot of CDC and other mental health literature is talking about the second wave of COVID, both being the physical pandemic that may be anticipated in the fall, but also as a mental health pandemic and a need for like a dramatic need for services. And so I think that now that everyone is delivering mental health services in some digital context, whether they're doing phone therapy, video therapy, SMS, text messaging, or by email, that we sort of now are forced to acknowledge that that this is a mechanism for delivering service that people will respond to, and that populations are finding useful.
So one of the things that I think people are really interested in is, how does it work? What are the actual mechanics of making this go, whether you're doing it on your own or whether you're doing it via platform? In our interviews, most of the practitioners we spoke with took the route of starting on a platform, and a platform really provides a bunch of the sort of logistical and procedural support. Some practitioners boldly set out on their own, and we'll hear a little bit about that in a minute. But even for people who practice face-to-face, I think all of us learned in our MSW programs about the arc of treatment, but very few of us learned about the mechanics or the business part of running a practice. So these are also concerns in the telehealth realm. I wanted to ask first Caroline and then Nicholas, how does it work? Everything from how you meet clients, what kind of training you get, how you find the clients who are interested in this modality, and then what is the telehealth equivalent of the things we're familiar with from face-to-face practice? Assessment, contracting, termination, and of course, how do you get paid? So Caroline, can you start us off?
Wow, that's a lot. I hope that I can hit all of them. Yeah, I did start with BetterHelp, which is a platform that at the time was really just doing text-based through typing long messages like emails. And they added telephone and they added video. And then moving from there into my own, so some of the other basically I joined any platform that was out there, I tried to get on it. And many of them offered some kind of little bit of training. For example, MD Live did a video orientation where you actually met with somebody one-on-one and they talked to you about what your space looks like and where you should be in the screen and whether you should be near or far and how to handle technical glitches. And I think that was really helpful because that information just wasn't widely available. And then I think a good middle step is, and also a good entry step really at this point, is joining one of the third-party platforms that sends you clients directly. For example, I was on Teledoc. Amwell is one of them. I think Laurie has a list of them somewhere in the slides later. And so they send clients directly to you, and you just get credentialed with them as if you were getting credentialed with an insurance company, but it's just with that platform. And that platform takes certain insurances, and then you have the option of whether or not to accept a case based on a little drop-down menu of what the issue was that they selected, and or whether to refer them just to decline the case and they get referred to somebody else. But basically, once on the user end, the client is able to look through a list of profiles of people who are licensed in their state and choose their provider. So it's a little bit more, I think it's a little bit better for clients in that they get to really choose who they work with. And it's a little bit better for the therapist in that there's not a whole lot of upfront work that you have to do. Just get your NPI, malpractice insurance, and get credentialed on that panel, on that platform, and you are getting clients. And then as far as launching into your own, there is a lot involved in that. You have to get all the same paperwork you would for a brick and mortar practice. You have to figure out how you're going to send it to your clients and receive it from your clients. And you have to figure out how you're going to meet with your clients, how you have to think about that client experience from start to finish, just like you would if they were coming to your office. Like how can they contact you outside of sessions? What are the conditions on which they should contact you out of sessions, and when should they not contact you out of sessions? You have to do the same assessment that you would do anywhere else. And then payment, there's a variety of different ways to collect payment as well. And of course, all of this is under that whole HIPAA framework where we have to always be trying to figure out and finding out about each of the platforms, each of the different systems that we use for documents, for video conferencing, for communication, for payment. Their terms and conditions change regularly, and we have to make sure that we keep up with that so that we're still in compliance with our state and federal laws as well. So it is a lot of work, but it's completely doable. And I believe there's freedom and flexibility in it, and we're able to service populations that we are really skilled at working with, that can find us easily, and it's just really convenient. Hope that got through all of them.
Yeah,
and in terms of termination, it's just like you would anywhere else. You have goals, you set goals with your client, you work towards the goals, and if you both feel like you've completed the goals, then you terminate. Make some policies about when you might terminate outside of the goals, and you would do that anywhere else as well, and you make sure you communicate them up front and throughout the course of treatment so that there's no surprises.
Mm-hmm. So a lot of what you're talking about mirrors kind of what you might do in a face-to-face setting.
It sure does, yeah.
That's interesting. Nicholas, what is your perspective on these same enormous list of logistical elements to practicing telemental health?
Yeah, kind of what Carolyn said at the beginning. When she was on a platform, I think the process is a bit streamlined because you are using a technology shell that's already there, and you're not necessarily creating your own. When I first started at Talkspace, There was a bit of an onboarding process. It was mostly getting acquainted to their particular platform, how things work, how to go through their different assessment models and such. So, I mean, it does eliminate that burden of the practitioner having to create all of that, whether if they were on their own platform. To the client assignment and attracting clients, from my experience on Talkspace, we don't necessarily attract or recruit our own clients. They are assigned to us. And so there are a few different ways that we can get them. When they sign up for Talkspace, they may be kind of triaged by a licensed professional, like licensed professional counselor, LCSW, et cetera, kind of does an initial brief assessment, and then based on their presenting problems and their needs, they're assigned to a therapist with that specialty. Some clients, though, don't have that initial interaction with, like, they call it a consultant therapist. Some may take an initial assessment, and then they're kind of assigned to you by algorithm based on, I don't know if it's keywords or the way, different triggers or flags in their particular assessment. So when you get them, it's completely fresh. So you have to, in addition to building rapport and implementing all of our clinical skills, you also have to educate them on how to use the platform. So there is a bit of a curve there.
And
if it's okay for me, for me to add, I think that the skill that it takes for a clinician on one of the platforms, like a Talkspace or a BetterHelp, to keep that rapport with the client is really, really crucial. And I commend those who are able to stay on those platforms long term. I was not able to do it because I just found it really, really hard to build that rapport. But that speaks to me and my rapport building preferences. And that's why I wanted to get off and just do video-based therapy. I know many people, and it sounds like Nicholas, who's been with Talkspace for several years now, who have been able to work in those platforms long term and be successful and help their clients be successful. So this speaks a little bit to attracting clients. Sometimes folks in our field who aren't entirely familiar with telemental health, they think that it's sort of a lesser service, and therefore they're reluctant to send their clients to somebody who's practicing virtually, or they tend to have it as less of a preference. And I would love to see us all get to a place where we can acknowledge that somebody else who's working within their scope of practice, who has training in this area, would know what clients they're able to work with and which ones they're not, and under which conditions they would. Even if Nick and I saw the exact same clients with the exact same issues, we probably would we would both work with them differently because we're working in different platforms. However, we could still be very effective for our clients.
As you guys speak back and forth, you bring up a lot of themes that we also found in our interviews with practitioners. Nicholas, I wonder if you could speak a bit to the kind of different modalities or packages, submodalities that are available via the platform. Caroline is talking about video, which is comes up as somewhat distinct because you can still see the client, but often on these platforms, clients can elect to pay for a different kind of service, a sort of messaging back and forth. Can you describe that a little bit, how that works?
Sure. So on Talkspace, just like you said, there are different modalities to engaging in therapy. There is message-based therapy, where you and the client just exchange messages. My experience as a therapist, that was a learning curve for me, to not be able to have that synchronous communication, that interaction with the client. So if you decide to practice in strictly messaging-based therapy, that's something to keep in mind, that you yourself will have to get comfortable and how to translate your clinical skills into just the written word instead of interaction. Talkspace also does offer video options as well for clients that select it. So I have quite a few clients where we have weekly video sessions, just like they were coming to see me in an office. We also have the option to engage in asynchronous video, where I can record a video, upload it, they can record a video, send it back, and the same thing with just an audio message. So it really just depends on what the client's preferences are and what the therapist thinks is an appropriate treatment, keeping in mind the client's preferences.
And do clients move between modalities? I mean, do you have people who start out messaging who request video, or do they stick with a single modality? How does that seem to work for you?
I find that it's very dynamic and fluid. I have clients that I may message throughout the week, and then we have a 30-minute video session once a week or once every other week. Some prefer like a 45-hour-long session once a month, and then messaging in between.
Interesting. Yeah. And Caroline, how are you meeting clients? Is it as it would be in face-to-face, where you have an appointment that is regular, or are people more flexible in terms of how they're communicating with you? And how do you determine sort of what their package is, if you will?
Yeah, so I offer an a la carte pricing plan, which the vast majority of my clients are doing video sessions. I mean, almost all of them. But if they want to do an email and, you know, in between sessions, for example, and that email is going to have clinical content, then they have that option. If they need to do a telephone call in between sessions, that's okay. It's part of the a la carte. But the vast majority of clients are just doing a video session like they would schedule, whether it's weekly, whether it's a standing appointment or it changes every week, whether it's every other week or once a month, much like you would do in an office.
Mm-hmm. And last question here, Nicholas, how do you work payment? Is that something that you have anything to do with on the platform, or is that largely managed for you? Because Caroline described how detailed it was to sort of manage both pricing and then actually figuring out billing. But for you, how does that work on the platform?
So on the platform, we have very little influence or control over payment. The platform does set the rates that they charge clients and then the rates that they pay the therapist. And most platforms, you know, the therapists are independent contractors or 1099s. So payment is about once a month, give or take. But yeah, we have very little interaction with the client. If the client does, let's say the plan they select is a text-based only plan, we can in the room populate different options if they want to like change to a video-based plan. But I, as the therapist, don't see any of their payment information. It's all done behind the scenes from us.
Interesting. Yeah.
I just, sorry for interjecting. One of the things we heard when we were interviewing folks who are doing this platform-based work in particular was how they felt engagement through writing was really something that some practitioners really gravitated towards. And they also acknowledged that if your clients' writing skills literally were limited, it made it more challenging to sort of to gain an understanding or to engage with building a relationship with a client in a way that that video, right, or even a phone session might lend itself to. And so people who are more comfortable writing and who enjoyed writing felt like they were more effective in an email modality or in a text message based modality. And they also sort of noted that you could press pause on a response in a way that you can't in a synchronous environment. And so it sort of afforded an opportunity to reflect a little bit, maybe more carefully or with a broader context than in a video environment where there's definitely pressure to respond immediately and to sort of continue a conversation, which is not for everybody. And so the ability to have choices both as the practitioner and the client, I think, is really useful. I'm going to advance our slide, and I'm going to say that I did not tell Caroline exactly that we were putting this in. She took the liberty of coming up with a handout that we will make available to folks after the talk, and I had to edit it to make sure that the words fit on the page. Sorry, Caroline, go ahead.
Sorry.
Caroline, do you want to go through your 5 telehealth tips that no one told you? I think this may be the most important takeaway of the day.
Sure. Good thing I have my little sticky on it from when I was working on that last night, so I can remember what these are for. But yeah, I think the first tip is to establish a cheering section. You got to get your group around you that is rooting for you, but also working with you. And they're hopefully working on developing telehealth themselves, just like I did in the very beginning. Number 4, nothing is a problem unless we make it a problem. That I stole. That's a quote direct from David Grand, the founder of Brain Spotting International. It was probably prominent on my mind because I spent a weekend in 9-hour-long everyday training for that. But I think it rings true in telehealth and social work. We tend to get caught up in the, well, how will I? And what if this happens? And this happened in my session and I don't know how to fix it. Well, it's not a problem unless we make it a problem. As long as we stay calm and we lead our client through the issue, they're not going to remember technical glitches or anything else that comes up. Even if your child shows up in the middle of a session, they're not going to remember that stuff as long as by the end of the session, they leave feeling better than when they came. Number 3, process is more than content. It's better than content. I think we have to be constantly checking in with our clients about how this platform or how this interaction feels for them, where it lands for them. And that's things like your camera angle. If your camera is down low and you're looking down to see them, are they feeling like you're looking down on them? If it's up really high and you're looking up, do they feel like you're a child looking up to them? How does it feel for them to sit in their home and talk with you, to sit in their car and talk with you, to sit on their bed and talk with you? So these are things to continually process with them, because there's those metacognitions that take place on the other side of the screen. That's really, really rich content for therapy if we can bring them to surface and work with them. 2, schedule in small breaks. So I've been seeing in a lot of the social media groups that people are just really Zoom fatigued right now. They're tired of staring at their screens. They're tired of not feeling like they're in the same room and engaging with people. So I have always done this in small spurts. I do 3 sessions. I give myself a 15-minute break. I actually go outside and breathe the fresh air, or I open a window. I might do a little bit of running up and down my steps to get my heart flowing a little bit. I might pick up my hand weights that I keep next to my desk. I won't say how often I do or don't pick up those hand weights. And then I'll sit back down and have another session or 2, and then lunch, a good gap in the afternoon, and then I do evening sessions. So it cuts down on the glare on your eyes or the strain on your eyes, but it also keeps your body moving. And I think it's important to send this message to your body, to neurocept, that you are part of the global world, you're part of the physical world, and you don't get completely absorbed into the virtual world. And then 1, always wear pants. and I find myself saying this a lot, and I don't know why, but I think it's really important to dress for work, even if you're in your own home, even if you're having a makeshift office in your garage. I think it's important to dress top to bottom as if you worked in an office. And, depending on your population, that dress may look different from clinician to clinician, but I think it's important to dress for work. And one of the things I had written in there is that you never know when you're going to need to stand up in the middle of a session and reveal what you're wearing below your top. And that is a warning from personal experience. So, and I won't share what happened, but but I was on video and it was slightly embarrassing. So always dress for work, always wear work attire. And that's it.
So we wanted to continue to ask you guys about your own experience. And we are really pitching here towards the idea that telemental health can be meaningful, it can be effective, it can enable clients to reach goals that they set for themselves. So starting with Nicholas, I'm wondering if you can share with us a case example when you felt telemental health was particularly effective, and maybe effective in part because it was remote, because it was virtual, where that was actually an enabling factor as opposed to something you felt you were trying to work around.
Absolutely. So I had about a year ago, and she lived in a very remote part of the state. So not a lot of mental health providers in that area. So there was the physical barrier to her seeking help. And she had recently lost a family member. She wasn't very technology savvy, but I think one of her children had signed her up for the platform. So that's kind of how she got there. So when she came on, she really didn't know what to expect. It was her first time in therapy, first time really practicing, really engaging with people in this kind of manner in a digital environment. And on top of that, you're experiencing grief from the loss of a loved one. So as we were building rapport, it was also a process of educating her to the platform and how to get to where she's comfortable engaging in that type of environment. And so what we did, even though she had chosen a text-based plan, my initial response was to offer an introductory video. Even though it's not covered by her plan, that is an option, just so she knows I'm a real person she's interacting with. We can see each other. We can have that face-to-face interaction, even if it is at a distance. So that was our initial way to build rapport. And then to help her with some of the technology aspects of it, I created just like a little cheat sheet, and I was able to share that with her in our room so she could reference it. Like, if you want to send an audio message, this is the sequence you can go through. I mean, that's really how we started, at a very basic level. Over time, as we built our rapport, as she got more comfortable with the platform, she started sharing more about her loss, sharing more about how it's impacting her life. So we worked together for about 6 months or so, and she thought she was at a place where she no longer needed the platform, which is good. As a therapist, that's what I want. I want them to get to that place where they don't need me anymore, as bad as that sounds. But yeah, so that's my success story, like in a nutshell.
Yeah. Caroline?
I wrote down two, if that's okay, because they were very different from one another. And one was an individual who was medically homebound and had no family support and no community support, and truly was not going to access the service elsewhere. And then I had another who was, this was while I was on BetterHelp, was part of a high control religious organization and wanted to get out. And that's not a specialty of mine whatsoever, but she was feeling really desperate to connect with somebody. And the individual was doing it from work. That was the only way the individual was comfortable, was to send text-based messages from a work device and not do it from their own home. And what ended up happening with that one in particular is that the work we did eventually enabled her to have a conversation with family to allow her to pull away from the religious organization and have their support. And then eventually, when I left the BetterHelp platform, she sought me out on my own. We were able to have video conferencing from her own home as well, on a completely different subject. So so in that regard, it's almost an example of, I was really working outside of my scope of practice, but this person was really desperate and feeling like there wasn't anybody else there that they could connect with. And just that relationship and rapport were able to give her the emotional strength to work through some issues and then be successful. So I think those are the two for me that stood out the most.
Those are interesting because we often, all of your examples, we often talk about telemental health as being attractive to people who might not seek therapy otherwise. And you are both describing clients who literally could not seek therapeutic services otherwise in a more traditional face-to-face modality. So that suggests a very, very literal realization of new populations having access to services.
The other thing I'd say about the individual who was medically homebound is that there are home-based services that may have been able to help that individual. However, in working with that individual over time, I was able to discern that there was an attachment disorder there that was also going to prohibit the individual from allowing people to come into the home and provide the service there. And so working remotely, it provided a little bit of safety, sense of safety, emotional safety. And we actually were able to work through a number of those dynamics as well.
We have been talking about sort of all of the great potentials in telemental health, and that is not to minimize the challenges. And you guys have spoken to the issues of building rapport, maybe discomfort with a technological platform, things like that. Themes from the research that we've done with practitioners is that there are populations and diagnoses that may be less likely to benefit. We found among practitioners that clinicians are really very, very responsible about making determinations about which kind of clients are appropriate and can work well in this modality in a virtual way, and do really a great job of being clear with people they don't believe they can help. But it may not be a modality for everybody, and clinicians over time really accrue experience about who they feel they have the most potential to reach. Uncommitted clients, I realize this is also a problem in face-to-face therapy. This is not unique to telemental health, but some of the platforms market via one free week. And so that attracts a population of people who kind of want to test it out, who are a little bit interested, or who maybe wonder if a therapist can solve some pressing problem they have in 1 week. That is not often a useful frame of mind in which to enter therapy, and practitioners did describe some frustration with clients who were not committed to doing the work of therapy, or who didn't understand therapy as an arc of work, an arc of relationship over time. For many, many practitioners, I think everybody we spoke with had started out in a face-to-face modality. Practitioners get very, very good at sensing information in the room. And so it's everything from how is my client dressed? Are they making the kind of eye contact I'm used to? What is their body language? How is it different from session to session? And even subtle things like smell. You know, how is my client's hygiene? Or does my client, who I know is alcohol dependent, smell a little different today? So how do you build up that kind of sensitivity to where the client is in the moment without actually being able to lay eyes on them? And as Lori said earlier, for some people, they get highly attuned to the words that clients choose in a written communication, the frequency of written communication. They begin to locate other clues to where a client is. And I think both Nicholas and Caroline have spoken to this idea of setting up the space. These issues, of course, come up also in face-to-face, but boundaries, availability, and expectations. Again, because some kinds of virtual therapy are available literally at your fingertips, are available literally in your pocket via your phone all the time. There is a sense in which some clients come to virtual therapy with expectations that a therapist is always ready to text you back. And in fact, this may come from some of the visuals that platforms use to market, where they have a photograph of your cheerful therapist on a headset standing by, waiting to solve your pressing concerns. And most practitioners we spoke to talked about having an initial period in which they really had to work with a client to say, yes, I am a real human being, and these are the times at which I'm available, and these are the ways in which I can respond. And last, I would say there is a kind of psychoeducation that both of you have described, which is therapy is different from magic. You can't log on, text me in desperation and expect to become a different human being. Therapy is work, therapy is relational work, and therapy takes place ideally over time. I'm not going to solve the problem you've come in with for you, and it's not going to be instantaneous. So these are some of the challenges we heard about from practitioners, and I think that you guys have spoken to all of those today.
And I want to interject for a second about this first point about populations who might be less successful in a platform environment. Lay and I have also looked at, and actually Nicholas and I have also looked at the terms of service agreements that in particular third-party platforms, this matching service are using that sort of serve as the informed consent piece before the client actually is even matched with a provider. And in those terms of service agreements, individuals, consumers, clients agree that that if they are suicidal, that they will seek treatment in other places. And one of the things we heard from practitioners that was a sort of particular challenge that people had to sort of use their own internal benchmarks on was what happens when you have a suicidal client. And we saw some practitioners who went to very great lengths in an anonymous environment with a client who was expressing suicidality to try to find that person and triangulate data on their own, independent of the platform, based on sort of the clues, the context clues that they had in the past from the client, where they actually sent a crisis team out to someone's home. And then that ran the gamut from sort of, I will go to this length to attempt to find a person who I might be working with anonymously, to I will not see suicidal clients at all. And so they would sort of try to set a really rigorous boundary about who was in their wheelhouse with regard to how they worked with clients. And that is a significant concern. And I think the platforms do an okay job of messaging sort of what they can handle and how they manage a crisis, including referring out to other suicide lines for those kinds of challenges, right, or issues. But there's inevitably a person who may not come into therapy thinking that they have suicidal ideation or a suicide plan, who then becomes suicidal. And so that presents a particularly unique challenge in the digital environment, where a client may be entitled to sign up anonymously, and then what do you do as the practitioner who is then charged with sort of really trying to crisis manage someone that they might not know where exactly that person is. So I say that to say, we also, sorry for the tangent, but we also can't see folks' questions, and I'm very conscious that we're coming up on about an hour. We will very shortly open it up for questions, because I'm sure that across our participants in this webinar, we have some. So we're gonna keep going and wrap up this slide portion so we can get to folks' questions.
And I would just encourage people to enter any questions you have in the chat. And at the end of our slide presentation, Kira is going to help us by kind of corralling those questions under some themes. And so you can ask these practitioner experts what you'd like to know. Case examples, I wanted to, again, turn to Nicholas and to Caroline. Like all therapy, telemental health doesn't always work. And there may be, as we just outlined, particular challenges and reasons why things might not be fruitful in a relationship, a therapeutic relationship with a client. So each of you briefly, Nicholas, if you want to go first, just let us know maybe the clues that let you know something wasn't working out and how you passed off a client who you felt might not benefit from telemental health.
Sure. Instead of a case example, I might just present like a broad theme I've noticed from my experience. As you mentioned, that some of the platforms do run promotions where they offer a free week of therapy or something like that. So you may get in clients that will initially engage with you and then just kind of disappear from that. Their free week's over, and maybe the cost is an issue, maybe the platform's not right for them. For whatever reason, they just kind of disappear from that. And that actually happens quite frequently when these platforms offer the promotions. The other just broad theme I see when therapy doesn't work well in a digital environment is when clients are assigned by algorithm. Sometimes that is not a perfect process. So even though the client may report to me as a therapist they're experiencing anxiety, but for some reason they were assigned because they had borderline personality traits or something. So the algorithm itself is not perfect. So as a therapist, I would encourage people that are interested in this, even though the client's completed like an initial assessment, to do your own assessment as well. Use your own clinical skills to see if that client is a match for your skill set. And then if not, we can help find an alternate provider that can get them the right kind of care.
And I had, when I was on BetterHelp, I had an individual who chose me to work because I had a perinatal mental health subspecialty, and I offered Christian-based counseling to those who wanted it. And the request said to the effect of, I just had a baby and I want to reconnect with my spiritual roots, and I might have a little bit of postpartum depression. And actually, we didn't talk by phone. It was just the text-based interaction. And from that, what I was able to gather was that her spiritual issues that she was bringing up didn't align with any particular faith organization or anything. And she was telling me about not sleeping. Of course, she just had a baby. She was a single mom. And some other things that clued me into checking more into her mood state. And she disclosed that she did, in fact, have a prior bipolar disorder diagnosis. So if you know anything about perinatal mental health, if an individual has a prior bipolar diagnosis, they are at increased chances of having postpartum bipolar and or postpartum psychosis. And so that's what I had. I called her. I asked her, we need to talk on the phone, like right away. And when I talked to her on the phone, I figured out that's exactly what's happening. And fortunately, and I explained to her that the platform was not going to work for her. Postpartum psychosis is an emergency. It requires immediate evaluation and quite possibly medication. And so I said, I need to get in touch with your emergency contacts. I need to get in touch with your OB, and we need to get you a psychiatrist. And all this needs to happen today, or I'm gonna have the platform send crisis to your house. And so fortunately, the platform, I gave them a heads up, and they said, okay, we'll be ready if you need us. And she was able to put me in touch with her OB, and her OB was able to do the legwork of getting her in with a psychiatrist right away. And then we discontinued working together.
Yeah. It seems like there's a bit of a duty around determining who you can help.
Yeah, exactly. And so is that something that I might see in an office? I might. And is that something that I might see online? I might. It's going to depend on the rest of the support system around the individual. But at that time, I did not feel like that was an appropriate setting for that individual.
Mm-hmm. Yeah, that makes sense. I think we're moving, on and through.
Yeah, on and through, and maybe even quickly. And some of these points we've talked about before, right? So there's an abundance of literature on telemental health, and I will give you some resources at the end of our talk about where to find some of that literature. But really, and these are a little bit of a narrow slice of who's appropriate for telemental health, including individuals who are hearing impaired. And so there's lots of functionality in digital spaces around closed captioning, and participating, engaging in psychotherapy via text, literal text, or text on the page. Individuals who've been diagnosed with dementia, those who are at higher risk of serious mental illness, and surprisingly, or maybe not surprisingly to practitioners and therapists, the VA has been very successful with telemental health, in particular with folks who are resistant or have some bias about coming into a psychotherapy office. And this last point, sort of not surprisingly, in the midst of a pandemic, research is really suggesting about how we can leverage digital service delivery post-disaster, right? So post-disaster recovery. And I think that we sort of are no longer able to say that you cannot do engagement engagement in a digital environment. We're all in a digital environment, to the good or not. I'm gonna hijack our presentation a little bit and take back our ethics portion and kind of reflect for a minute about this anonymity question that we were just talking about with regard to what we heard from practitioners and high-risk clients, and the interrelatedness of high-risk clients, anonymity, and competence. And so one thing, or among the things we heard from practitioners, is developing a skill set for having the ability to say that I am not reaching this client. I am not able to serve this client. This is not something that the platform is able to navigate successfully. As I mentioned before, informed consent in digital spaces are mitigated to some degree by, if you're on a platform, by the terms of service user agreement that the platform puts forward before someone even gets to meet a client. So one thing we heard from practitioners was that they were kind of replicating the face-to-face informed consent process after they had initially engaged with the client, after the client had signed the terms of service agreement, because in some cases the terms of service agreement on the third party on the platforms indemnifies the practitioner and the platform from delivering service. And I'm happy to talk at length about what that means in like literal terms in practice outside of our webinar. In terms of policy challenges raised by platforms, I'm going to let Caroline speak to this licensure question because she has very intimate experience with trying to deliver telehealth services across states and where we may or may not have reciprocity agreements. Caroline?
Sure. So as Laurie said early on in the webinar, that telemental health has been delivered in some format for decades now. And with the growing availability to do it through these different platforms or independently, has the question of whether or not we can work with a client who is not located in the state where you're licensed. That question comes up all the time. And so early on, what was happening was people were asking the question, and some people were doing it regardless, seeing clients regardless of where they lived, and some were not feeling comfortable doing that. And so people started asking their state boards for some clarification on what the requirements are or whether it's allowed. And so the way I see it is what happened was the state boards decided we're going to make a decision about this and we're going to say no. And that was with the intent of protecting the clients, protecting the public. But I think that what they really neglected to do potentially was any research on what was already happening and what social workers and other counselors were doing in order to work competently and ethically with clients in different locations. And so they just said no. And what it ended up doing, unfortunately, was cutting off services for a number of people. And what it meant too is that in the past, if you were on vacation and your client had a crisis and wanted a session and you were willing to do it, that people would do it. Or if the client was away, or if the client maybe had a death across the country and they needed to go be there for it, but they also really wanted their session, clinicians would do it. And now the ruling is pretty firm that we can't do it. And so I think that what was meant to be protective of the public has in other ways been more harmful to the therapeutic process, but also to the individuals that we service.
Thank you. I think we're going to skip to one best thing about telemental health or one challenging thing about telemental health so we can jump into questions. And Nicholas and Caroline, either one of you, please tell us what's the best thing about telemental health or what's one challenging thing about telemental health before we jump to questions.
Go ahead, Nick.
Okay, thanks for putting me on the spot, Caroline. Sure, the best thing about mental health for me is the ability to reach clients that I wouldn't be able to reach otherwise. And it's a benefit for me as a therapist, obviously, but also a benefit for clients to reach or to have services that they may not be able to reach for whatever barrier might be facing them.
A very social work answer. Very good. Mine is convenience. It does feel really good when a client says, I'm so glad I was able to work with somebody who does something that I need, because I don't have that in my area. But it was a convenience benefit for me. I'll kick off challenging and then I'll throw it back to you, Nick. Least favorite thing would be, it's pretty socially isolating. I used to work in the clinic that I was leaving. I was there 1.5 day a week up until last summer. And I realized within about a month or two of no longer going there that 1.5 day a week that I was really starting to get antsy, that I wasn't seeing human beings on a day-to-day basis and interacting with them and walking past them and driving past them. And so I think it's still important to get out because it's pretty socially isolating.
I will build off of your answer. It is socially isolating, also in a professional sense. So if you want support from your peers, you will have to take the initiative and build that network or seek out that network on your own.
Sorry, thank you. Kira, can you start us with questions?
Yes, I sure can. Turn my video back on. And I'm actually going to email them all to you as well so that you can see them in writing. I know that helps me sometimes. And luckily there are some sort of buckets or themes to questions, and you've touched on many of them, but maybe can go a little bit deeper into some of these questions around licensure and reimbursement. So you talked a little bit about licensing and licensing in states and how that might apply if you were working with clients in other states. But there's been a few questions about how folks who might not be licensed yet can become a clinician this way. Are you only assigned clients that you are licensed to serve? So whether that's clients in your state or different varying needs depending on licensure in different states. I'll turn that question over to you now.
So I'm going to just give the headlines and then I will turn it over to our practitioners. So what we heard in our research was that and it was exclusively on third-party practitioner therapists, practicing on third-party platforms, was that the platform in lots of cases would assign people from anywhere to a practitioner from anywhere. So some of our therapists were assigned clients from overseas, from people who had expatriates who had been in the US and were now overseas and seeking psychotherapy in a way that where they didn't have insurance in the country where they were living in. Other practitioners were just assigned people from Europe who just didn't, for whatever reason, were not able to seek services in their home country. Often people were assigned to therapists who were not in their same state and or did not have state reciprocity. And so I think that from the platform's perspective, licensure is less of a challenge, but from the practitioner's perspective, almost to a person, the practitioners, the social workers, knew what the guidelines were based on their state, and in some cases had gone to great lengths to get the information they needed from the state licensing board. Caroline or Nicholas, can you add to that for us?
Yeah, sure. From the platform, I'll second what you said about getting clients from multiple states or international clients. I will say it's gotten better over the past maybe 2 years, 1.5 years or so. So I'm licensed in 3 states. And I would say I reliably only get clients from those states. I have gotten international clients, and it was a new experience for me because I didn't know or fully understand how that would work operating under my license here. And just as a sidebar, I reached out to the ethics line of my liability insurance provider, and their response was, you aren't violating any laws or rules in your home state of license. The issue would run into wherever the client's residency is. So the client I got that was international was in France, so I could run afoul of French social work laws. I opted to take the conservative route and not practice with that client since I'm not licensed in France.
I think there was also a question about whether practitioners who aren't yet licensed at all can service clients in this modality. And what we know from the platforms is that platforms are hiring people with a clinical license. You have to have a clinical license to be authorized to work on one of these platforms.
Sorry, there was also like a sub question about fees and payment, and I know a little bit about that, but our practitioners know a whole lot more about that. Caroline, can you speak to fees both on a platform and how you bill in your private digital practice?
Okay, so the fees on the platforms that I've been on are going to be different than the fees that Nick gets on Talkspace. When I was on BetterHelp, it was kind of like a word count based fee or a time in a session based fee, and there were maxes on how much you could make per client per month. When you're on your own, you set your fees. And when you're on your own, you can take insurance as well, which means the insurance sets the fee. And on something like Teladoc or Amwell, or I can't think of some of the other ones as well, those third-party platforms contract with certain insurance companies. So the insurance pays the platform. I think this is an important note for access as well. If a client is seeing a therapist in their office with their insurance, and that insurance has a specific telehealth platform that they cover in network, and the therapist is not paneled on that platform, then most likely the client cannot see that same therapist remotely, which is I think it's another issue for access. And it's another thing that hurts clients more than therapists. But those platforms have set fees, and the average is around $50 per session. Some are paying a little higher than that, and that's nationwide.
Thank you all. Another question is around language access. Is there technology that incorporates language translation services into digital therapy?
Practitioners, help us. So I can tell you what I've seen trying to do peer groups in an international context. The software is actually shockingly limited, and there's some conversation about using Zoom in international contexts where you can do breakout rooms in a range of languages, and there's a maximum of the number of rooms. So you can use those services in particular ways. Microsoft Teams has a translation function. It's really clunky. I think that it would be not impossible, but it would definitely add a layer of complexity to building a rapport with a client in a different language. We did have one practitioner in our sample who was participating in an exclusively text-based environment with a global focus, and they had the ability to do translation because it's slightly easier to translate a text sentence in text to a text sentence in a different language. But in terms of real-time translation, there's not really yet any good solutions for that. Here, other questions?
Yes, I was giving Caroline and Nicholas an opportunity in case you had any separate thoughts, but no one unmuted, so that's my cue.
Kira, you're muted.
Try again. One other question was around if folks can define what a high-risk client is within this realm, whether that might be different from those that might be deemed high risk in sort of a traditional therapy setting.
I can speak to how I determine high risk. I don't know, Laurie and Leah, if you have research on high risk at all, or Nick, how you determine high risk, but I think that high risk is determined by the provider. Just like if you had a brick and mortar practice, you would still work within your scope, and you would have crisis plans for what you would do in certain situations. You have to do that if you're going to work remotely as well. And so what I consider high risk might not be what somebody else considers high risk, and what someone else considers high risk, I might be very comfortable working with. So, so it's very provider specific. I'm comfortable sharing what I do, what my I guess what my measurements are. I will not take a new client if they had an inpatient psychiatric hospitalization in the last 12 months. And if I'm working with somebody, if I do an assessment and they express some suicidal ideation, then I'm going to do a full suicide assessment and determine the risk of suicide. And then if I determine that risk to be at a moderate level, if I can plan with them and I sense from the way I would have worked with them in person that this plan is going to work, then I'll work with them. If I don't, then I'm going to refer them to a crisis center.
And I think what Caroline just said speaks to a theme that we discovered very broadly, which is that the practitioners who choose to work in this modality are creating their own protocols and assuming that responsibility. So in every dimension of ethics that we looked at, informed consent, privacy, this issue of competence, high-risk clients, the practitioners are creating protocols, they're creating the forms to collect the information they believe they need to practice responsibly with clients. So it's not, even if you're on a platform, which assumes a lot of the logistical or mechanical responsibilities of practice, practitioners are still working hard to ensure that their practice is ethical. And often that involves creating a professional learning community, pooling resources with other people who also work in the same modality, or creating supportive documents, practices, procedures, and protocols that allow them to do the work in the way that they feel is ethical.
I just add lastly, the platforms in particular, these third-party platforms, they're by and large technology companies that are kind of serving this matching function, marketing psychotherapy. And in some ways, it's been a real boost, I think, to psychotherapy that the platforms have become involved because their marketing budgets have been much larger than any individual practitioner might be able to promote on their own. But if you go to the platform's website as a client, it basically says in terms of high risk or serious mental illness, it essentially says that this is not a substitute for a psychiatrist or for a crisis unit. And if you're in danger, call 911. And that's their sort of limit of liability. And I think that it's really, it can be really beneficial for folks who want to kind of experience delivering psychotherapy digitally as kind of a first step. I think it's a great opportunity, but they are fundamentally, at the end of the day, tech companies. And Caroline alluded to this a little bit in the fee structure of some of them. We were really surprised to find that it is. They're tech companies, and it's an Uberization to some degree of mental health services. And so I think there are some opportunities to sort of develop new skills, but there are also some challenges in terms of how even the platform as a host thinks about the work.
And we just received a question asking about any recommendations you all might have for communities to join or to belong to support kind of the isolation and clinician support that you all spoke about earlier.
Yeah, so there are a few out there. I know there's a few therapist support groups on Facebook. I believe there are some like Twitter channels you can follow. I don't really use Twitter, but I've heard of others that where therapists can share some resources and stuff. Maybe Caroline knows a little bit more about that.
I was going to say the same. There are groups that there's so many of them that you can pretty much just type in teletherapy into your preferred social media platform and you will likely find one. And then I think forming one as well. And so being in a group and asking people does anybody want to work together on some of these steps to kickstart our practice? I think it's really important to have that support. And for me, it's the accountability of knowing that I have a meeting at a certain time with people who are relying on information from me. So create your group and or join the ones that are already out there. But just know that if you're getting into this, you are not reinventing the wheel. There are already people who have done it, a lot of people who have done it, and they're very willing and eager to help you out as well.
And then one final question, which I think probably poses us for a follow-up webinar entirely, is around any tools or materials that you would recommend for MSW programs to introduce and prepare students to use this teletherapy modality.
So yes, so let me jump slides a little bit. So we have I would suggest for Caroline's handout in particular, email her, and I have put her her website here. But I also put up on my webpage just a section called digital telemental health resources, and it's broken out by, there are 2 credentialing bodies. There may be more credentialing bodies, but when we were interviewing a year or 2 ago, there were 2 sort of big credentialing bodies that are offering a certification in telemental health services. You know, those credentials are only, let me stop there. If you want to have a credentialing conversation, I'm happy to speak with you offline. But there's credentialing bodies. There are folks offering CEU trainings. There's some really nice academic literature about the effectiveness, certainly, of telehealth. And I put, we sort of organize those on a page on my website. And I would encourage you to follow the social work tech hashtag if you are on Twitter or social media. It's a really active group. It's probably 70% academics who are interested in sort of understanding how we can better get students engaged with this work. And so people have lots of ideas for curricula and how to do this work better, and to sort of promote the idea that practicing in digital spaces is equally effective to face-to-face environments.
Those are all of our questions. Want me to wrap us up?
Yes, please.
Yes. Okay, I will wrap us up. We just want to take a moment to thank you all for joining us and acknowledge that this is the first of a new webinar series that the Grand Challenges is hosting that is all focused on how we can harness technology for social good. If you aren't familiar with the Grand Challenges, feel free to check out our website. It will be listed at the beginning of this presentation, which you'll receive a recording of by email as soon as it's ready. It usually takes about 24 hours to turn it around. But we hope that this information was useful. I want to thank all of our panelists for being willing to go first as part of this series. I know it's a big undertaking, and there's been great comments and great questions from the participants. So thank you all for joining us. I am going to ever so kindly kick you all out and end the recording. And we hope to see you on our next webinar.
Thanks, Kira.
Thank you.